Coarctation of aorta. Aortic coarctation represents 4% of all congenital heart lesions, and male to female ratio is 3:1. Coarctation of aorta is hemodynamically significant narrowing of the aorta, usually present just proximal to the site of insertion of the ductus arteriosus distal to the left subclavian artery. The narrowing of the lumen is due to deformity of the aortic media. Without repair, the average survival is 35 years due to heart failure, dissection, or rupture. The exact cause of aortic coarctation remains unknown. However, the two most prominent theories involve the ectopic ductal tissue and the hemodynamic perturbations. At present, there appears to be greater support for hemodynamic model, wherein the abnormal ductal flow or decreased aortic ischemic flow lead to developmental aortic coarctation. Genetic factors play a role in the pathogenesis of coarctation. However, most cases are sporadic. The patient with Turner syndrome have a 30% risk of having coarctation of aorta, and there is also a suggestion of the familial clustering of the congenital outflow tract lesion. Coarctation can also be acquired lesion from inflammatory arthritis or Takayasu or severe atherosclerosis. In utero, 2/3 of cardiac output bypasses the aortic constrictions via the patent ductus arteriosus. However, the PDA and the foramen ovale begins to close. Blood must pass through the constricted segment of aorta, and this can result in the acute onset of the cardiac failure. Depending on the degree of narrowing, this can lead to LVH and developmental collaterals from intercostal central memory artery and supraclavicular blood vessels. Coarctation is rarely the only lesion present associated with the bicuspid aortic valve, VSD, aortic stenosis, patent ductus arteriosus, hypoplasia of the aortic arch. Additionally, 1/3 of the patient may have more complex cardiac defects such as single ventricle physiology, atrioventricular canal defect, or transposition. The narrowed aorta produces increased left ventricular afterload and wall stresses and left ventricular hypertrophy, the congestive heart failure. The systemic perfusion is dependent on the ductal flow and collateralization of the severe coarctation. Neonates may remain asymptomatic, and they have a PDA. This patient may present with a cardiac failure when the ductus closes. The symptom of diaphoresis, poor pallor, and dyspnea diminishes the femoral pulses. The older infants and children, usually milder degree of coarctation, may report the chest pain, cold extremities, or claudication may come to attention because of the collateral hypertension or murmurs due to associated lesions. Adults, similar to children, may present with hypertension, claudication. Additionally, they may present with a heart failure, aortic dissection, or hypertensive urgency or emergency. The prenatal versus postnatal. Difficult to diagnose on the prenatal ultrasound as a minimal cardiac output flows across the defect, and the presence of the postductal posterior shelf is suggestive of coarctation. These patients are followed closely after birth. Physical examination, gallop rhythm with systolic or diastolic murmur, prominent carotid pulsation, diminished or absent femoral pulses, as well as hypertension or in upper extremities, and minimal blood pressure in the lower extremities. Chest X-ray shows rib notching in chronic cases. ECG, biventricular hypertrophy, T-wave inversion. Echocardiogram shows diagnostic clearly delineates the coarctation, and other associated cardiac lesion can estimate the severity. CT angiography may be required in the complex cases of the long segment coarctation or the abnormal arch-sidedness or branching. Cardiac catheterization rarely required in early stage, typically reserved for the children, and the complex defect associated with coarctation when there is transcatheter intervention. MRI is non-invasive alternative treatment. The medical management with prostaglandin E initiation shortly after birth can keep the ductus open and provide perfusion to the descending aorta in the neonates. The physiologic derangement should be corrected prior to the surgical repair in the critically ill neonates, and the mechanical ventilation and the inotropic support may be required in some circumstances. Balloon angioplasty is the treatment of choice for recurrent coarctation after the surgical repair, but has too high for recurrence rate and procedural risk to be considered in the primary intervention. Stent placement done for children more than 6 years of age has excellent outcomes similar to surgery. Surgical intervention indicated for symptomatic neonates or infants, and for older children with adults that are not candidate for the catheter intervention. Asymptomatic patients should be offered surgery if the upper extremity blood pressure is 2 standard deviation above the diameter of the coarctation is less than 50% of the diameter of the remaining aorta. Procedure is performed by the left posterior lateral thoracotomy with direct or extended end-to-end anastomosis, then minimizes the amount of residual ductal tissue. A tubular vascular interposition graft may be used in adults, however, the aneurysm formation and the lack of growth limit the potential for the interposition graft repair in the younger children. Other techniques such as the subclavian flap aortoplasty may be performed if necessary, but has fallen out of the favor due to possible long-term limb complications. The techniques of operation include the subclavian flap, end-to-end anastomosis, and patch angioplasty. And the prevention of recoarctation, ideal operative procedures successfully adverse the transverse arch hypoplasia, resect all ductal tissue, prevent of residual circumferential scarring, and a younger age of operation, and presence of aortic arch hypoplasia remains a risk factor for recoarctation. Regional cerebral perfusion, we begin cardiopulmonary bypass at a calculated baseline of 150 mL per kg, further adjustment at the baseline cerebral blood flow, and RLLP provides the consistent cerebral circulatory support, and that support is bilateral despite being applied to the innominate artery. Neurological complication, the incidence is 2 to 3% in overt clinical presentation, up to 60% when sensitive magnetic MRI is applied to the heart. In control of the arch proximal to the left carotid artery during COA surgery, this assumes that the collateral blood flow and completeness of the circle of Willis allows for a favorable even distribution of the cerebral blood flow. But the patient undergoing coarctation repair proximal to the occlusion results in the transient but significant impairment of the collateral cerebral oxygen balance. The blood supply to the spinal cord and the exposure and LSCA flap, patch augmentation, subclavian artery flap could also be applied. End-to-end anastomosis can be performed after resection. Extended end-to-end anastomosis. And these are the site of resection anastomosis. Resection and extended end-to-end anastomosis. End-to-side anastomosis. Enlargement of VSD. Resection of the conal septum. The complications include the chylothorax, bleeding, paraplegia, and recurrent phrenic or recurrent laryngeal nerve injuries, post-coarctation syndrome, ileus abdominal pain, mesenteric vasculitis, visceral infarction. Also possible. Good post-operative blood pressure control is essential. Patients who have undergone coarctation repair remain at the risk of several complications, including the chronic hypertension, recurrence of coarctation, and aneurysm formation. Patient will require a serial long-term upper and lower extremity blood pressure measurement. These are the operative mortalities, which include paraplegia, hypertension, upper body hypertension, late aneurysm formation, valvular disease, congestive heart failure, bacterial endocarditis. Special features of the postoperative care: systemic arterial hypertension management, abdominal pain, and cardiothorax management. Postoperative hypertension should be managed. Paraplegia should be managed with the duration of spinal anesthesia, duration of the intercostal arteries ischemia, intraoperative proximal hypertension, postoperative hypertension, hypothermia, anastomosis with tension, and acidosis in the period of perioperative period. So these are all the factors that lead to paraplegia. Special situation, if it is proximal to left subclavian artery with mild to moderate coarctation, and prevention of paraplegia with collateral circulation and hypothermia, descending aortic pressure under 50, recurrent coarctation increases the mortality and morbidity, and coarctation of aorta with VSD and other abnormalities increase morbidity and mortality. Balloon dilation. There is a rule of balloon dilation is controversial because of the early re-stenosis, the need for multiple intervention, and potential limb ischemia and increased risk of aneurysm formation. The mechanism of early re-stenosis in neonates may be related to multiple factors, including ductal tissue constriction, recoil, isthmus, hyperplasia, intimal hyperplasia as a result of smooth muscle cell proliferation, and matrix protein production with arterial remodeling and involved re-stenosis. Thank you.